Welcome to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. And on these weekly mini episodes, we bring you bite-sized ideas for you to snack on.
Like breathing exercises, book reviews. Maybe we'll review some scientific research, or we'll share some wellness and fertility stories from our listeners.
So if you're looking for a tip or a trick related to your fertility and well-being, then you've come to the right place.
Let's dig in.
We are so happy to welcome back Dr. Angela Hernandez. Hopefully you could listen to the main episode where we covered a wide range of topics related to pelvic pain and especially adolescent pelvic pain. But we are really happy to have her back again with us today to talk a little bit more about endometriosis and especially the genetic and potential family component. We hit on that a little bit in the main episode, but I think there's more that we want to talk about.
Always more. There's always more. Thank you for being back.
Yeah, no problem.
I was just so shocked in the main one when you met. What was it? Like you said, 7 times the risk of endometriosis if you have a family history?
Yeah, that's what we're classically taught. So patients with a first-degree relative with endometriosis are 7 times more likely to have it themselves. So definitely a high suspicion when I go through the family history and I hear about pain and early hysterectomies and infertility issues as well.
And is there any research in terms of genetics? Do they know any kind of markers, or where are we in terms of being able to do any sort of screening?
Yeah, that's a really great question. And again, I wish that I knew all the answers to it. I know people are investigating this, but I mean, honestly, Anne, at this point, we don't even have an ultrasound marker for it. I mean, it'd be really cool to get the genetics of it and just, have it be run along with your food sensitivity tests, like whether or not you have endometriosis, but we don't even have reliable ultrasound or imaging modalities to kind of determine endometriosis. So again, just going off symptoms.
Well, in the fertility realm, I mean, there's lots of tests out there. One of them is if we do an endometrial biopsy that they're claiming that you can have some sort of markers that come back on that might indicate endometriosis. It's all very controversial in the field whether you go with that, because much like what we talked about in the main episode, if someone already has the symptoms, you need to treat presumptively whether or not a test tells you that someone might actually have it. And if it comes back not indicating endometriosis, it doesn't mean that someone might not have it. So you're right, we're definitely not there yet in terms of all different kinds of modalities.
Yeah, exactly. And specifically with my adolescent population, where a lot of them can't even tolerate a speculum exam in clinic, while an endometrial biopsy would be great, especially if we could get a definitive diagnosis.
No.
No.
Endo biopsies are my least favorite procedure to do. And we do some pretty invasive things. And in terms of technical difficulty, it's one of the easier ones, but man, it is not a lovely thing. We had mentioned in the longer episode that, to get that formal diagnosis, you have to have that surgery to look on the inside of your pelvis to see if we see those endometriosis implants, but that doesn't necessarily mean if we don't see it that it's not there. So I just went to the Endocrine Society conference, and there actually was a couple talks on trying to figure out the genetic markers for endometriosis, and it was a little bit over my head. There's a lot of mouse models and knockout mice. I was just I don't know, but I just know what I gathered from it is they're working on it.
Yeah, exactly. But until then, we'll use hormones.
Definitely. Like you said in the main episode, you're really treating not just the patient, but often the family. And so how do you sometimes approach that conversation? I'm sure that's a situation where maybe you're actually having parents that are more worried than the child themselves, if they're coming in more in that early side and, they're maybe more concerned about endometriosis than the actual teenager is.
Yeah. And, my NP friends from back home and I used to joke that maternal endometriosis should be a modifier when it comes to billing, because it really does. It really does alter the visits.
I'm sure. And it comes from such a place of love and support, though. If you felt like you had to go through this whole long journey and this is your child, of course you want to do everything you can to not have them have the same experience.
Yeah, exactly. But it definitely changes the tone of the visit, because frequently if you have a parent who themselves struggled with endometriosis, endometriosis and all the fun things that it comes with, they're bringing their kid in with their very first period. And, you talk to the kid and you're like, okay, so like, what are your periods like? And, they're like 11, 12, barely making eye contact, shrugging their shoulders, like, probably recording a TikTok at the same time as the visit. And they're not really giving you a lot of info in terms of my periods are really painful and I want to do something about it. A lot of times these kids aren't even bothered by their periods yet, but their parents are bringing them kind of for that prevention. So because we do know that they will be at a higher risk for endometriosis, I do talk through all the options and leave it there. But ultimately, right, it's the patient's decision. And sometimes the parent is a little bit more, oh, you need to start these pills to kind of prevent these symptoms. But if the kid isn't going to take them and doesn't want to deal with that every single day, then that might not necessarily be the best thing for them.
I could see how if you yourself had endometriosis and it took, five healthcare providers and 9 years to get a diagnosis, like I certainly would be on the ball too and trying to get my kid some treatment sooner rather than later if I was worried about it. But yeah, it just brings up the point that it is a shared decision-making process. Everybody has to be kind of on board with the plan and understand the options that are out there.
Yeah, exactly. And I'm not about to stick an IUD in a 12-year-old under anesthesia just because that's what helped their parent get through it if they don't want it themselves. And they haven't really had any of the symptoms either. So.
And sometimes we've seen situations where, usually at a slightly older age, but I have had people come in where the parent wants them to talk about fertility preservation because they are concerned about, especially if they had struggled to conceive and they went through infertility and they finally had this most wanted child, then I think sometimes they do feel like in their minds endometriosis equals infertility, and that's not necessarily the case. I mean, you're certainly at a higher risk, but how do you have those conversations when you're trying to balance so many unknowns?
Oh, yeah, I mean, with infertility being as common as it is today, I usually just try to normalize it by saying, even without endometriosis, even without PCOS at this rate, what statistics? I mean, you guys are better experts at this than I am. Like, I usually tell people 1 in 8. Is that
that's still the number.
Okay. Yeah, good. Just making sure. I tell them 1 in 8 people struggle with infertility, and because of that, I tell them that there are great doctors who can help with that if they find themselves in that situation. But on the other hand, they could definitely also just get pregnant spontaneously and not have any issues with this. So, I do sometimes we'll touch on what's available out there. I usually spend a lot of time reassuring them that if we do elect to start hormonal medication, and even if we continue it for extended periods of time, that our research shows that should not affect their baseline fertility. That tends to be a really, really big question among hormonal management in young people, especially if a parent struggled with infertility themselves. They're worried about if I start them on the pill at 11 and they continue it until they're ready to have a kid at 30, like, is that going to make them sterile?
And I have had some people who I think, don't quite understand how it all fits together. And I've had people kind of seem bitter about the time they were on the pill because like, oh, it was masking my symptoms. Yep. I didn't even know I had this until I went off it. And it's explaining like, but that was actually a good thing.
It could have been worse.
Masking your symptoms because it was treating you. It wasn't like it was like hiding you from having this diagnosis sooner. So I feel like there's so much misinformation out there about the impacts of it.
Exactly. Exactly. And it's also, too, whenever I'm counseling an adolescent about LARC or long-acting reversible contraception, I always start off with being like, what have you heard? What have you seen? Like, because people are out there. People aren't standing from the rooftops talking about how much they love their Mirena. Most of the time they're talking about...
I would.
I am. I tell everybody I love my Mirena.
But more commonly you'll hear about how all the negatives to it. So I think it's really important to direct adolescents to age-appropriate information. The website I frequently will give them is the youngwomenshealth.org website. It's Boston Children's website that they actually have an endometriosis center. So they have numerous handouts on there that are age-appropriate for endometriosis. Whereas if you were just to Google endometriosis or search endometriosis on TikTok, you're like looking at people in their 30s and 40s who can't get pregnant, who have gone through multiple surgeries, who have been told a bunch of other things. These handouts are like, hey, what does this mean for you as a teenager? What are your treatment options? And what are some things you have to think about down the line? So I really try to keep it age appropriate.
Yeah, and it's such a tough balance too, because you don't necessarily want to have people needlessly worried about their fertility. I mean, you want to be aware, you want to know how you can manage, but I feel like if from a young age you're worried about something happening, that's not great for your psyche as well. And we talked earlier about how anxiety can play into this. And so I think you're right to focus on the things you can't control, the choices you make right now, how all these things are protective for future fertility, and not think that it automatically is going to equal challenges. Because we've also had people who think they don't have to go on contraception because they're told, oh, I have endometriosis, I can't get pregnant. And that's certainly not the case either.
For my PCOS population too.
Oh, for sure. That happens a lot. Yes. And, it also goes to show that having endometriosis does not mean that is going to be, if you end up having fertility issues in the future, that might not be the reason that you're struggling to conceive. It might be an incidental thing. It might be contributing, but it could be like your parent warned you about endometriosis, that you're going to have endometriosis for sure, and got to be very careful about it. And then comes later that, yes, you have fertility problems, but it's for a whole nother thing.
Yeah, so, exactly.
Yeah, you can fall in love with someone with bad sperm. It can happen. So yeah, don't just assume. But that's part of the reason that we always do tell people, if you know that you have risk factors, whether that's family history or you have been told when you were younger that you had something, that's one of those situations where those guidelines for how long you have to try don't apply. So if you are ready in a place to try and you know that you have endometriosis, you don't have to try for that full year before you go see somebody.
Yeah, and for somebody with a family history of endometriosis, even if at that moment in time their periods aren't necessarily painful, I do still point out the other benefits of using hormonal management. Like, are they an elite athlete and using hormones for menstrual suppression? Would that be advantageous so that they could swim all the time or do gymnastics all the time and not have to worry about their period? Are they struggling with acne, and would using an estrogen-containing compound help with their complexion? We don't necessarily have to do it just for periods, but knowing that they're at that higher risk, maybe we are also helping to prevent that spread.
Yeah, it's a whole person approach, so taking into consideration multiple things. It also makes me think that, we've been talking a lot about genetics and how definitely, and for so many things, genetics does play a role, but it's not the full picture. So you definitely can they somehow identify the gene that turns endometriosis on. There are other things that can turn those genes on and off. So there's things like epigenetics, what we're exposed to, and our environment, our lifestyle, our diet, things like that can also play a role in the severity or whether you actually do develop. So your genetics are not you're not predestined for everything that your genetic makeup says.
Yeah, that's one of the controversies as we do screen for more potential multifactorial conditions. Like, just because you have something that might have a risk of something doesn't necessarily mean you're going to have it. And we get most worried in the field about things where people are taking actions. Like if you find out you have a breast cancer risk and you're acting to, but I mean, I think things like that are on the potential for endometriosis too, that if you don't, knowing that you have a risk for something still doesn't mean that you're going to have it. And so it's all about how much information you want to have in the moment, and especially what you're going to do with that. I think that's something you talked a lot in the first episode. If I'm not going to treat you any differently based on the results of this test or that test, do I even really need to do the test?
Yeah, exactly. So when patients come in asking for the surgery to tell them if they have endometriosis or not, if they still have no interest in starting hormonal therapy afterwards, it's a conversation where it's really just like, well, even if I go in there, if I find it, the treatment will be hormones. If I don't find it, the treatment will be hormones. So if you are not interested in starting hormones, you're essentially saying that, and don't get me wrong, a diagnostic laparoscopy is like my bread and butter surgery, but everything comes with risks. When I consent somebody for a diagnostic laparoscopy, I'm talking about things like pain, bleeding, infection, damage to the surrounding structures, where the surrounding structures that could be really scary are, large blood vessels that when I'm trying to get in there, those are going to be in danger, going to be close to your ureters, your bowel. You're putting all of that at risk. And that's not even talking about the risk of anesthesia in general and the recovery time from that surgery. Just for curiosity, and if you're not going to, do treatment afterwards. It's a conversation that, I have with all my patients. And again, shared decision making. Is doing the surgery the best thing for you, or is it kind of an unnecessary risk right now?
If you have people who it is because they've had, a family member that had surgeries, or do you feel like they're more or less likely to want them to have a diagnostic surgery?
I think it really depends on the family member's experience. I've had some patients who have had family members who had, because as you guys know, endometriosis can be terrible in terms of, scar tissue and adhesions. And so we have patients whose family members have gotten hysterectomies that were complicated by bladder injuries, by bowel injuries, needing, all sorts of extra care because the endometriosis was so bad. And for those patients, they're like, I really don't need the surgery. Just give me the hormones. Because they're like, well, when my parent got their hysterectomy, they ended up in the hospital, and then they pooped out of a bag for a few months until things could heal up. And they don't want that to be them.
And I know, Anne, you've brought this up in prior episodes before too. We run into this kind of similar thing when we talk about fertility preservation. When is the right time to do assessment for your ovarian reserve? It kind of helps to think about what you're going to do with that information. Is it something that if you have that information now, are you in a place that you're able to do anything about it?
Yeah, especially with someone with endometriosis, if they were, say they're into their 20s and they're not foreseen wanting to have children in the near future, but do have it as a goal. We have had some people that they come to talk about freezing eggs, and often, especially because there's been a family history. But as Ruby said, there can be more than just endometriosis. They might also have an issue with egg supply. And so I think it's only good to be checking for AMH to talk about egg freezing if someone's actually in a position to do it. Because otherwise, if you find out that maybe there is an egg supply piece on top of endometriosis, but if someone's not financially or emotionally able to do anything about it, well, now you've just added one more source of anxiety and stress. And, just like having endometriosis doesn't mean you won't be able to get pregnant. If you find out you have a low egg supply, it also doesn't mean you might not get pregnant. It's just one more factor that's going to maybe be a challenge if it doesn't happen naturally. And we're trying to give people the information that they need to make good choices without making them feel overwhelmed.
Exactly.
It reminds me of, when I first started here, and I had been working here for several years, and the topic of AMH came up, and everybody around me at the lunch table was like, oh yeah, mine's this. And I'm like, oh, I've never tested my AMH before. And they're like, you haven't tested your AMH? And I'm like, I don't know. And then a couple of years ago, I was starting to get hot flashes and things like that. So I'm like, am I menopausal? So I just checked my AMH, and it wasn't menopausal, but it wasn't great. And I was like, well, you know what? I'm actually really glad I didn't know that before I had children, because knowing my personality, and I would have been freaked out about it. Yeah. Now, getting pregnant was not my problem. Other things going on, but that was not the problem. So it just shows that sometimes knowledge is power, yes, but other times it might not be as beneficial as you're initially thinking it is.
Yeah, if you can have mother with endometriosis as a modifier, you should have fertility nurse as a modifier, because everyone that works here gets completely concerned about their fertility.
Oh, I got my AMH drawn on the second day of my REI rotation.
Yeah.
So. Yeah, I think this is really helpful. So I know we talked a lot about, adolescence and that early kind of that diagnostic, if people are caught early, but I think all the things we talked about in the main episode and in this one can be applied to people that are trying to figure out where their pelvic pain is coming from in their 30s or their 40s.
Yeah, for sure.
All the things we don't talk about as a teenager, we don't talk about them in our 30s and 40s either, in terms of constipation. And
yeah, and a lot of it really is just like you guys said, the piecemeal factor of our healthcare system. At the end of the day, your internist or your family medicine doc probably only has 15 to 20 minutes with you to address your one complaint, maybe two. So when you come in talking about pelvic pain, it's okay, well, I'll get an ultrasound and go see your OBGYN. It's not okay, well, how often do you poop? Are you stretching? What's it like when you pee? Do you have any stresses at home? That kind of stuff. Whereas one of the luxuries that I have being a pediatric and adolescent gynecologist is that my new visits, I get to sit down and take time. That's why I make the list and the checklist and really kind of get to know them. The follow-up visits aren't going to be as long, but for that initial visit, it's going to be a lot of talking, a lot of list making.
I love it. That sounds...
I know. We love all those things. You're great to talk to. So I'm sure everyone wants to come see you now.
Awesome. Thank you so much.
Well, thank you so much for your time. I think we've learned a lot, and I really appreciate you coming to share this with our listeners.
Yeah, no problem.
Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review The Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.